Okay, I think we're going to go ahead and get started. It's 12:05, and it seems like a great time to do so. Again, I just want to welcome everybody. Welcome to Health Research Live, Vaccine Research and Initiatives. My name is Marco Staffney. I'm the Executive Director of the Montshire Museum of Science and your host for today. Our program is produced and organized by the Montshire Museum of Science, the Public Health Council of the Upper Valley, the Dartmouth-Hitchcock-Norris-Cotton Cancer Center, and Dartmouth-Hitchcock Population Health. The COVID-19 pandemic has shown a spotlight on vaccinations in the larger conversation of public health. Today, Elizabeth Talbot, New Hampshire's Deputy State Epidemiologist, and Christine Finley, Vermont Department of Health Immunization Program Director, will discuss what vaccination research and initiatives are taking place regionally and nationally, what the future of the COVID-19 vaccine looks like, and how we can apply what we know from our experience with other vaccines to get the public vaccinated. So Health Research Live works in a particular way. Each presenter will talk for about 15 minutes, and then we'll be breaking up into virtual Zoom rooms so that you can have smaller group discussions about what you've heard for about 10 minutes. We'll then come back for a broader question and answer session that we'll host through the chat feature. So without further ado, Elizabeth, I will hand it over to you.
Hey, I'm very happy to be here with you today, especially as it's such a fast-moving field. I have had to even update my slides this morning. So thanks for sharing this hot off the press information. And for a change, it's good news coming from this pandemic. So our focus today is going to be to talk about indeed the COVID-19 vaccines and try to put some framing around whether they are safe, effective, and equitable as they're coming to you. So the first thing I was asked to take on is just to make sure that everyone understands these phases that we talk about in the vaccine landscape arena. I think the New York Times does just a fantastic job of describing this in really accessible terms. So I've captured this screenshot from now more than a week ago, but it's relevant that when we talk phase 1 in vaccine development, this is really all about making sure the dose is right and it's safe. It's actually a fairly small number of people who participate in this stage that allow the vaccine then to go to phase 2. These are expanded safety trials. So now we start to approach dozens or even hundreds of patients. But all the news these days is around phase 3, which is tens of thousands of patients with emphasis on efficacy. That is, does it work? And in the meantime, given that so many more people are receiving it than were in phase 1 and 2, it gives us a very important insight into safety as well. We talk about vaccines that are in limited approval. These are for example, the Russian Sputnik vaccine and a vaccine in China that have not come through the traditional landscape development pathway. And then, of course, what we hope for is to get into the far right, which speaks to those that are fully vetted and approved through the normal pipeline. So that's where we're focusing right now. We're hovering between phase 3 and approved, and let's see how that goes. So this is the latest information that if you turned on your computers or checked the news, you would have seen. Pfizer has their fullest data analysis completed. All of this has been done in record time. So now we have information on more than 43,000 participants who have been appropriately accrued to represent racially and ethnically diverse persons, and also adults, even into the extremes of age. I'll start with what I think is the important news as we start to consider whether we're going to stand up to this vaccine and whether we're going to promote it to our friends and families and patients and et cetera. There was no indication of any adverse safety signal. And I think the numbers, as described, 3.7% experiencing fatigue and 2% with a headache after the second dose, is lower than we expect for even some of our currently available vaccines. So this is great news. And even that those side effects, which were rare, were less common among those who are in the older age groups. The analysis of their endpoints, which is sort of creepy science way of talking about symptomatic cases, showed that only 8 among vaccine recipients were documented. This translates to an efficacy of 95%. And that is at the time point of 28 days or longer after the first dose. So this gives us a sense of how long it'll take to achieve immunity. I find it extremely reassuring that these efficacy data appeared equivalent across race and ethnicity, and were similar also among those in the older age bracket. So not only lower side effects, but also equal efficacy is just a wonderful combination. There's another signal that's emerged from Pfizer and also Moderna, which I'll talk about in a moment, which is that of those breakthrough cases, those cases of COVID-19 that were documented among those who received vaccine or the placebo, only 1 of 10 of the severe cases occurred among vaccine recipients, suggesting that even if you get disease after you've had the vaccine, it's going to prevent some of the worst outcomes for you in terms of hospitalization or even death. So Moderna had their interim analysis out a little bit later than Pfizer, and we still don't have their final analysis. This is just a slightly smaller study of 30,000 participants, also striving for racial and ethnic representation. And their interim analysis has been translated to a efficacy of 94.5%. And all 11 severe cases of COVID-19 were among those who received the placebo. So what I find remarkable is how consistent these 2 messenger RNA vaccines have performed in very well done, large and independently scrutinized studies. So there's some really exciting information just in these last few days. Operation Warp Speed is the name of the program that HHS has put forward. It's a bit of a complicated arena here, but I think you get the notion of how this vaccine would move from a laboratory eventually to those who need it most, and then we could track following to make sure that it is indeed a safe vaccine. But the point of this graphic is to draw your attention to this very unusual stage of the trials going on at the same time as manufacturing has been funded by Operation Warp Speed. So this is not the usual way. So much about this vaccine development has been really unprecedented and historic that it's hard to know where to draw attention, but in fact, what gives me courage that we will see this vaccine in a much shorter order than we have for other vaccines that have come through those approval phases is that there has been an active manufacturing going on in our background while we wait for this data. So I have often said and say again, I think that the name of this program has been an unfortunate step. You know, I just don't think we want warp in the name of a program that we're going to have to promote to our stakeholders in a really coherent and clear way. These are the other vaccine candidates that we're watching very closely. I draw your attention to Johnson & Johnson vaccine in part because the features that are favorable here are that this has already proven to be an effective platform when it was called into action for the Ebola epidemic in West Africa and the Democratic Republic of Congo. It also has the very nice feature of being a one-dose vaccine. AstraZeneca is also using a similar platform, and then Novavax is one that's been heavily supported by Operation Warp Speed with a more familiar approach to generating immunity. The famous protein subunit vaccine, it does have a modern twist using nanotechnology to secure this immune reaction. The other aspects of this table that I imagine already your eyes are drawn to are some of the incredible challenges that are going to face us with regards to distribution around the fact that the Pfizer vaccine requires such an extreme cold storage and the fact that it's 2 doses separated by 21 days. Moderna also requires freezing, but not to the significantly reduced temperatures as Pfizer. It's also a 2-dose series separated by 28 days. So there's a lot to say about some of those logistic features, and I think that we're going to come to that with Christine's perspectives too. But in summary, we're on this really tight timeline where I'm getting some of my news from headlines each morning. Pfizer is expected to submit their dossier to the Food and Drug Administration and request their emergency use authorization. Moderna will be a week or so behind. Once the FDA reviews, they've asked for the public to understand this will likely be 2 weeks, maybe shorter if they work day and night, but right now we want to temper expectations and expect 2 weeks. They will then review with the Vaccines and Related Biologic Products Advisory Committee to make that recommendation, and then it goes to the ACIP, the Advisory Committee on Immunization Practices. So these steps are typical for vaccine coming to market, but are just so significantly accelerated. Again, the companies are producing doses, and we really are expecting vaccine, as incredible as it sounds, probably in either late November, more likely early or mid-December. So the rubber is hitting the road. I think that you have anticipated that we're not going to get all the vaccine we want right out of the box. In the beginning weeks, we're going to have a highly constrained supply that dictates a highly targeted administration. And so we've had to think about priority populations. Of course, there will be larger amounts available over time, and eventually we'll shift to a routine distribution. But I think this is not surprising to anyone. And therefore, like many states, we've had to, in New Hampshire, think through very carefully the allocation framework. The goal is really twofold. So just to be very intentional about that, it is to reduce severe morbidity and mortality, and also the negative societal impact due to transmission of the disease. And our allocation criteria are one or several of these populations that have risk of acquiring infection. Think healthcare workers on the front lines of caring for patients. Severe morbidity and mortality. Maybe you think those older than 65 or with medical conditions. Those whose disease can have severe negative societal impact. Maybe the people who are working at the nuclear power plant, for example. And then those who have risk of transmitting infection to others who might be vulnerable to disease, like healthcare workers, but also teachers and other members of the critical infrastructure. And we've landed with 4 allocation phases. It's just so important for me to always make sure that it's understood we have guiding ethical principles here. This is not an arbitrary process, but has been vetted many different times and ways now to look for ways to achieve maximal benefit. We have equal concern for every person having equal dignity, worth, and value. And that's relevant when we hear occasionally people say we should divert it from the very old. We are not making those distinctions in value of years of life. We are looking to mitigate some of the health inequities that have been so vividly exposed during the course of this pandemic. So we are looking for that ethical distribution across those who have been disproportionately impacted by this. Our guiding procedural principles: fairness, transparency, such as a talk like this, and making sure it's evidence-based. That has been a huge challenge, of course, because we're getting data very rapidly, and it is a full-time job keeping up with the evidence base that's emerging. So here are those 4 phases. We are heavily engaged with a laser focus on the jumpstart phase of 1A. This will be health workers, first responders, and older adults living in residential care facilities. We'll then move to people who have the comorbid and underlying conditions that put them significantly at risk for morbidity and mortality, for getting sick and dying, and then other older adults living in congregate or overcrowded settings. In phase 2, teachers, critical infrastructure workers, maybe others, definitely others that have comorbidities that don't reach the criteria of severe. Those who are in congregate settings like homeless shelters, group homes, and then people in correctional facilities, and then all older adults not in phase 1. Phase 3 starts to look like everybody else, especially with a target toward young children young adults and children. And then phase 4 is just anybody who didn't have access in the last round. So please do review our plan if you're someone residing in New Hampshire. We're trying to keep up the resources. This is our website, newhampshire.gov/COVID-19. Resources and guidance is a drop-down, and you can actually peruse the plan yourself so that you're better acquainted. But I would hazard that many of you might be in a position to talk with your doctors or employers about receiving this vaccine even within a month. I think that's just, remarkable news that's come to us in such a short order. So really, I look forward to your comments and questions that arise as you think about this together.
Thank you so much, Elizabeth. That was really informative and great. And we'll have some time for the whole group to be able to talk with Elizabeth later in the program today after we have our small group breakouts. Now I'm going to turn the talk over to Chris Finley. Chris, I'm going to ask you to come up onto the spotlight here, and you can feel free to share your screen.
Good afternoon, everybody, and thank you for inviting me to join you. And we've been working so fast on this that it's a pleasure to learn what's happening in New Hampshire and listen to Elizabeth, because that's the first that we've gone over that. I will say that for those of you in Vermont wondering what we're doing, if we're doing anything close, it's very similar. The allocation and guiding principles were provided by the National Academies for Science, Engineering, and Medicine, and we've been using those also. And I'll talk a little bit more about that going on, but be assured that it's very similar. Elizabeth beautifully laid out the different phases that the vaccines are going through. And one of the things I was asked to do is address safety. So I wanted to use this because I think it's a nice pictorial to show that safety is assessed at every step along the way. And if you look between the green and the blue, that's where we are with the Moderna and the Pfizer vaccines, with expecting the emergency use authorizations to be submitted in the very near future, is they'll be moving into that FDA review where the FDA does have an advisory committee. The one other thing I'd like to highlight is that after a vaccine makes it through the FDA and is reviewed by the Advisory Committee on Immunization Practices, it's still, the safety is continuing to be monitored over time. I just wanted to put this quote, and I apologize, I forgot to put where I got it from, but that before a vaccine is introduced, it's really important that we prioritize and think about what's important for vaccine acceptance, because we can go all the way down one path and do all this exciting stuff and seeing new vaccines, but if the public isn't ready to accept them, we'll never be able to reach the herd immunity that we need in order to stop the pandemic. One of the things I wanted to highlight is we hear a lot about manufacturers reporting initially on safety because they're doing the phase 3 studies. But the US government has a major responsibility for the public safety of vaccines, because vaccines are, for the most part, typically given to healthy people. And the work that they do is independent from the manufacturers. And they have a very large safety monitoring system that I'll just mention their names a little bit. And the agencies collaborate on monitoring. So the FDA coordinates with the CDC. One other piece specific to the COVID vaccine that I wanted to mention is that when the advisory committee is reviewing a vaccine, they form a work group, and these work groups have representation from not only science and academia, but those that are implementing it, and really often are very representative across the US. One of the unique things they did with the COVID-19 work group is they created a vaccine safety technical subgroup, and they will independently be reviewing and evaluating the safety data and monitoring the after it's either authorized or licensed. They'll be monitoring that and sharing that at the ACIP meetings. And those meetings can be streamed publicly if ever you're interested in looking or hearing at some of that stuff. The next meeting is Monday. So large hospital systems all come together, data from them are brought together under the Vaccine Safety Data Link Project and the Clinical Immunization Safety Assessment Project. And what this does is help to answer questions about vaccine safety. And some of those questions may have come from what's known as VAERS, and that's the Vaccine Adverse Event Reporting System. And that is a very large system. Providers can enter data into it, patients can enter data, manufacturers can enter data. It's meant to be a signal system. Everyone can enter into it, but what it's really supposed to do is just give us a signal quickly if there is something going on that needs to be further assessed by the other groups. And then I'll just mention that the CDC is creating a new smartphone-based surveillance system that they're hoping to launch in the next 1 to 2 months called vSafe, that would allow people to report in real time any adverse effects and provide extensive monitoring. And this is brand new, and we're just seeing this. And I think I have a note down there that healthcare providers are very important in reporting any concerns that they see so that we can follow it closely. So this, as I mentioned, is the adverse event reporting system, and this is managed by the CDC and the FDA. It's something that we look at carefully with the Vaccine Safety Office at CDC for all vaccines, not just for COVID vaccines. I wanted to switch a little bit. I was asked to talk about some of the confidence. And the CDC conducted focus groups for COVID vaccine before the most recent surge that we've been facing. And the first 2 bullets, I think, kind of hit it, that they were generally open to getting it, although, you know, from the news, we've seen some decrease in that acceptance. But there's been this hesitancy and this wait and see. And I think it goes back to what Elizabeth talked about with Operation Warp Speed, and talking about billions of dollars and making the vaccine the fastest it's been made. I hear even healthcare workers and providers have, said, I need to know more. And the most common concerns that the focus group showed is that people were worried about safety, wondered about effectiveness, and testing and the rapid development. But note that these focus groups were done prior to the releases that we've had this week with the data from Pfizer and Moderna. And why do people want to get vaccinated? They want their life back. And oftentimes it also has to do with trust in the scientific process. The CDC is providing guidance to providers on improving confidence and to the public. And one of the things I just want to highlight is, for the most part, people are very confident about the safety and the effectiveness of vaccines. We know when we look at, in Vermont, at our school data, 94% of our kids between kindergarten and 12th grade are up to date on all the required vaccines. That's a large percentage. We know there's people with concerns, and I think it's important that the concerns are voiced. But for the most part, despite the increased hesitancy in the last decade, there is some confidence. A new vaccine being that was co-produced at the same time that it was in phase 3 is a new concept we need to get used to, but it doesn't mean that safety was compromised. And I think that's what's important to understand. This is the slide that Elizabeth shared, that's a CDC slide. And I think that she covered all of that. Really, we'll have limited doses in the beginning. We expect that very quickly we'll have larger doses available. And the idea that it's going to be available possibly in mid-December is just amazing to me right now. The Vermont Department of Health has got an advisory committee regarding COVID vaccination. And right now, what we're doing is finalizing 1A and discussing 1B. We're using the same principles that were outlined before, and we're trying to make sure that we address the critical infrastructure and the risk. And equitable distribution is extremely important because much of Vermont is rural, and we need to make sure that those that are healthcare workers or in congregate settings or long-term care, whatever, that they have equal access regardless of whether they're in the Northeast Kingdom or down in Chittenden County or in Central Vermont where I am. So I want to stress that we see that as very important. We're at the point where we're enrolling hospitals in the beginning. The one part I'll mention is that we've been encouraged to provide mass vaccination clinics in the beginning to address those that are at highest risk, and then we'll be going more with the normal vaccine distribution. And so just to end, some of the strategies we're working is the equitable access to vaccine, monitoring uptake and coverage in critical populations. And one of the things I'll say is the federal government has offered to provide vaccine to long-term care facility residents. And we had 100% of our skilled nursing facilities and assisted living facilities sign up for that. So that's a place where they will come in and provide the 2 doses. And we feel we're pleased to see that is fully planned. Looking at how we're going to reach the populations with low vaccine uptake. And we're partnering with hospitals, we'll be partnering with EMS, with many people. And one of the pieces that we're also working with our State Emergency Operations Committee on is how we supply and reposition the vaccine to ensure that we have not only equitable access, but that we fully use all the doses that we have when we receive them. And I'm actually looking forward to the part where we get to discuss and I get to hear questions. So that's it for me today.
Great, thank you so much, Chris. I am going to stop sharing your screen and start sharing a different screen because we're going to enter into our small group conversations now. So as a part of Health Research Live, what we do is we break out into small groups. You're going to be automatically transported into a small Zoom room with about 6 to 8 other people. And then after about 10 minutes or so, we'll come right back into a question and answer session. We have 3 discussion questions that you can work on. What concerns or challenges have you heard in the community about vaccines? How can community organizations and community members support confidence in the COVID vaccine when it is available? And what questions might you have for our presenters? So our suggestion is that when you get into the small breakout room, you spend about 30 seconds just introducing yourselves and then take a look at these questions. We're going to put these questions in the chat box for everybody. So if you want to be able to remember those questions, just take a look for your chat. And again, we're looking at what concerns or challenges have you heard in the community about vaccines? How can community organizations and community members support confidence in the COVID vaccine when it is available? And what questions do we have for presenters? We do ask our recording entity to stop recording at this time. We can record back at the Q&A. And we are back recording live for the question and answer session. I always like to tell my group that they're the best group because they get to have their questions asked first as an entree into our Q&A session, which we have just about 10 minutes for today. So one of the big questions we had was such great appreciation for both of your time to be able to talk to this community about what's going on. But from both states' perspectives, what is the communication plan that's happening in both states to make sure people are feeling comfortable or knowledgeable about the vaccination protocols for COVID-19?
Perhaps I'll start then. I want to recognize that people get their information from different sources. They're able to take in evidence from different sources. We're different one from another. So for some people, they'll only believe what their doctor tells them. For others, it might be their priest or rabbi or et cetera. I think they're in some degree of trust to the community leaders. So in New Hampshire, we're looking at every trusted voice for educating them and providing them the information that they need so that they can then be the spokespersons for this. So this was true. I responded to the Ebola epidemic in West Africa, and just a remarkable life lesson for, it might not be a doctor, it might not be your nurse, it might be your religious leader, your community leader or so. So we're making an effort to reach everybody who might be a spokesperson for this.
I would just say that we're looking at the importance of not only working with the public, but also addressing providers to make sure their questions are answered, because we know how important they are with that. We're building on what we've learned from the work that we've done on COVID. One of the pieces that I think we really want to build on and is that the importance of community leaders. Dr. Levine, I know, has become a very trusted resource, but we also, I believe, have others in communities that are very trusted. And I think having them, bringing it down more to the grassroots level so that it's not always so high. And I think one of the pieces that our communications team is working on too is we need to reach out to all populations. And we may use social media a lot, and that may be effective in some ways, but there are people that don't use social media, aren't interested in it. And we need to be thinking about what venues are out there that we can tap into to share our message. So a lot of that is going on.
Excellent. And a lot of questions coming in about this particular program. Where will this information be found? So we're working with our partner CATV, which is our public access station here in the Upper Valley, to be able to promote this at a wide range, as well as this will be on both of our YouTube pages, so that we'll be able to disseminate this information in this great presentation. So utilizing the Monshire as one of those resources, and as well as public television is something that we're doing. So I'm happy for a lot of those questions coming in. A couple of questions specifically about administering the vaccine, and is this a one-time only vaccine, or is this something that would happen seasonally?
Yeah, it's a two-shot series, and we simply don't know. Obviously, it's been developed over the last 8 months, and we don't have the kind of duration effect to know that right now.
And is there any indication if these new vaccines which are being made come out, and then at a later date there's a better vaccine, would you be able to be revaccinated?
Yes, probably. Sorry, I've interrupted some, Christine, I think, but just to say one important point about the two-shot series of the Moderna and the Pfizer is that you have to complete your series with the same one. They're not interchangeable. But we are hopeful that indeed better vaccines will come along as described, maybe one dose and one that has that kind of lifetime protection. We just don't know. But in which case, when that happens, we'll update recommendations.
The one thing I would say is to see 94 or 95% efficacy is incredible, and to see very minimal side effects. So the two doses, either 21 or 28 days apart with these two, is challenging, and we'll be looking forward to seeing some others. But I think that this new platform is going to be a game changer. I saw some preliminary information yesterday that said that it's looking like in terms of, they're looking at antibody response, but just in terms of how long we think vaccines will last for this part, we don't know that there's preliminary data that's just being looked at in the beginning that might be hopeful.
A couple of questions about taking the vaccine, not taking the vaccine, and tracking who takes it and doesn't take it. So this is a unique experience. How are the states thinking about tracking who takes the vaccine? Will there be state registries put in place?
I can answer for Vermont. So we have an immunization registry, and CDC is actually requiring information. At first they said within 24 hours, and now they've said 24 to 72, when many states said, are you kidding? How do we get it in that quickly? We have had to sign data use agreements working with them. And in Vermont, we have a rule where we don't share any identifiable data. And many states have that, and we're able to work with them, because one of the things that they need is a national picture, which is understandable, but they also don't need identifiable data to have that national picture. So we have had an IT group working since early July full-time on meeting, ensuring that we're able to not only meet the reporting requirements, but that we can inform people when their second dose is available, and also to develop a whole registration, to work with CDC in developing a registration system for the mass vaccination clinics. So if I were to show you some of the graphs, your head would spin, but it's being worked on. And I will say states have been very clear on their restrictions with limited data sharing.
Do you think that there will be consequences for people who don't take the vaccine? This is not unprecedented in the last 100 years, but for our times now, do you think that states will mandate a vaccine?
I personally don't. Institutions can, but the state of New Hampshire certainly won't. And there may be rules around that in the longer term until it comes to full approval. Right now, the EUA will not allow the states to mandate it.
I completely agree.
All right.
I actually think a mandate could take us backwards, because I think forced, in terms of perception of risk and being forced to do something, oftentimes can decrease its acceptability.
So clearly, both of us many of us living in a bi-state region on this particular program, a lot of questions and concerns coming up about healthcare providers in one state or another, since many of us go from one state to another for health, specifically the Upper Valley, Vermont side, going to Dartmouth Health, Hitchcock Medical Center for most of their healthcare. Will you be able to get that vaccine out of state, or if your healthcare provider is in a different state?
Yes, we are going to provide vaccine to persons at their medical home or within the regional public health networks. So those are often cross-border folk.
Yeah, but we have years of experience with this. We, both of us have universal vaccine programs for children. And if a Vermont child is seen in New Hampshire, they'll get those vaccines that New Hampshire pays for, and it goes vice versa. So we've worked that out over years and are familiar with that. It's great, I think, that we have such cross-border work going on.
Yeah, really nice.
All right. Just a couple of questions have come in about other types of aggregate living situations and each state's thought on what we saw in the presentation, were residential facilities, elder care. But I think one of the pressing concerns for many of us is universities that have come up specifically as, I can look at Dartmouth College outside of my window. Have thoughts about where university communities fit within the dissemination plan, whether it be UVM, UNH, Dartmouth, the larger colleges around the states?
Well, indeed, residential persons in whatever category of residents are going to be prioritized, because we've watched this virus sweep through and disrupt society. So remember the twofold goals that are obvious: reduce morbidity, mortality, but also just get society going again, which will include educational facilities. So our residential schools and universities, K-12 and universities, are well within our sights for the second phase of distribution.
And I've just received a lot of questions from our Vermont colleges. There's a group that meets all the time with the health department, looking at how can they, what I love was one of the questions was, how can we support you? how can we use our students to help you? And then also saying, if they need to be vaccinated, can we be enrolled? What can we do? So already the outreach has come from colleges saying, when the time comes, let us use our assets to try and work with you and help with this.
Excellent. We just have a couple other questions that we have time for. Here's a more of a nitty-gritty question. Why are the RNA delivery vaccines going faster than the other methods?
Frankly, because they're easier to produce. So the very simple, I called it a recipe or RNA template, is pretty easy to make in a lab. So I think that this is one of the reasons it's been looked at for an emerging infectious disease vaccine platform that we could ramp up quickly, just as we're seeing. So remember, every year when the flu vaccine is made, and like you have 1 billion eggs, and it's grown up, and sometimes there's not enough eggs to make it, and so this has the potential to ramp up very quickly, more so than some of the previous and more usual technologies that we've used for vaccine.
The one thing I'll add is that the genetic code, which was necessary for this, was shared by China very early in the process, right, Dr. Talbot?
Yeah, January. So really, as early as possible, we've had the whole genetic code of this organism, so we've been able to take these steps from the earliest stage.
It's a good story in collaboration in science. One thing that people have had questions about is the potential risks of the rapidity of Operation Warp Speed. Anything that you two would care to comment on?
So what I'm seeing, and I'm human too, and I told you already, I don't like the name warp in any program where somebody's going to stick something in my arm, or my kids' arms. I get it. But what I'm seeing is clearly the same rules that have been applied to every other vaccine, but just in a unusually funded and condensed time frame. It almost speaks to me that this is the time frame we should have for every life-saving intervention. But rather, we've been lulled into a complacency of allowing vaccines to take years to come to market. So maybe to reframe it, that this is a time frame of going through the usual phases and landmarks and independent reviews that we always do, but just on a faster timeline.
Yeah, I think also the willingness of the federal government to put billions of dollars into allowing manufacturers to make vaccine, which they didn't know whether would be shown to be effective and safe, or might have to be thrown out. I mean, that's something a manufacturer just doesn't usually do. So that's increased the time frame. But I want to get rid of the word warp and speed.
Got it. I hear that. Well, and with that, our Warp Speed program today has come to an end. And I want to thank you both so much for your time. Both of our speakers today, audience, are in between other presentations throughout the day and throughout the week, and probably for the next few months. So your time with us is so valuable, and we appreciate you being here. We always like to get feedback on our Health Research Live programs, and so we actually do have a small survey that I'm putting up in the chat that just takes you to a Google form just to fill out a couple of questions to give us a little feedback about what we might do next. Our next Health Research Live program will be about advances in telehealth, and will take place on December 16th at noon, and information about that will be found on the Montshire's website, www.montshire.org. With that, thank you so much for participating in today's program, Health Research Live. I appreciate everybody's time, and good luck out there. Thanks.
Thank you.
Thanks.
Thank you, Chris. Thank you, Elizabeth.